Assalamu alaikum. Good evening, everyone. We will be starting in 2 minutes from now, just allowing a few more participants to join us. Good evening, Maher, Hiyam, Sabah. Good evening, everyone. Wa alaikum salam. Welcome, Ghattas. So now the event is live on Facebook as well. Perfect. Okay. Bismillah ar-Rahman ar-Rahim. Dear respected ladies and gentlemen, Assalamu alaikum and good day for all of you from all around the world. We are excited to kick off 2022 with our first Journal Club event. Our mission in IVPN Journal Club, for those of you who are joining us in this journey since we established in 2020, is to share the latest published evidence, learn from high caliber and world-class pharmacotherapy experts in analyzing primary literature, read beyond the trial's context, ultimately to optimize clinical practice. Tonight, we are a gathering of 400 delegates who joined us to enjoy and learn about a very important topic that highlights a promising, rich area for pharmacists to excel, shine, and influence direct patient care. With our passionate presenter, Dr. Lina Al-Harbi, and distinguished expert, Dr. Umayma Al-Arab as well, we will be discussing about the role of pharmacists in ambulatory care and how to establish effective, successful, and sustainable ambulatory care services led by pharmacists as part of an interdisciplinary team. And now I will hand the floor to our amazing moderator, an integral part not only in the Journal Club listserv, but in IVPN growth and success, Dr. Shahama Al-Jum'a. She is a designer in our IVPN network and the Journal Club listserv. She is part of the aesthetic committee as well. She is now practicing as hospital pharmacist in Dr. Sulaiman Al-Habib in Riyadh, and she earned her Doctor of Pharmacy degree from Al-Marifa University in Riyadh as well. And she is peer reviewer as well for multiple journals, and always a star where we are always proud of her presence and contribution to IVPN. So Dr. Shahama, we are honored to have you with us as moderator, and all the best in this impressive and very promising event with Dr. Lina and Dr. Umayma. All the best. The floor and mic is yours, Dr. Sham.
Thank you so much, Dr. Ahmed. It's always a pleasure to be one or part of this amazing listserv the Journal Clubs serve. Assalamu alaikum, everyone. Today we are discussing a very critical topic for pharmacists, which is the evolution of pharmacist-led in ambulatory care. Starting our webinar today with a passionate and ambitious presenter, which is Dr. Lina Al-Harbi. Dr. Lina graduated with a Doctor of Pharmacy degree in 2022 from Taiba University in Medina, Saudi Arabia, completed after that a 10 months internship in 7 different patient-focused institutions. She's also pharmacy class leader for the academic year of 2019-2021. She also had a volunteering activity with Saudi Crescent Authority and several community events with a pharmacy club at Taiba University. Now she's working as a full-time pharmacist at Al Nahdi Medical Company. With a great pleasure for having you today, Dr. Lina. Dr. Lina will also be discussing today about the successful model of pharmacist-led ambulatory clinic and training practice change lessons for improved patient outcomes. With a great pleasure, Dr. Lina, without any further delay, the screen is yours.
Hello, everyone. I would like to thank the organizer of this meeting for inviting me here today and for the warm welcoming. It's an honor to have the opportunity to address such a distinguished. My life is you is a journal club presentation on the effect of pharmacist-led program in improving outcomes in patients with type 2 diabetes. Before I start, you can scan the QR code to pull the full article. I have divided my presentation into 5 main parts. I will start off with the background information, then I will discuss 2 previous studies. After that is next I will move into the study overview. After that is the study critique, which is the main part of this presentation. Finally, we will be looking at the impact of the result in on the practice, and I will share my final conclusion. My presentation will take about 20 minutes. Statistics have showed that in 2019, just under 500 million people are living with diabetes worldwide. And then this number is projected to increase by 25% in 2030 and by 51% in 2045. So what does this mean? It means that there is an urgent need to develop and implement multidisciplinary strategies to tackle diabetes. So according to 2022 American Diabetes Association guidelines, that a patient-centered collaborative approach should be used to optimize patient health outcomes and the quality of life. And patients with diabetes can benefit from multidisciplinary team, which include pharmacists. So the question here, what can pharmacists add? We will back to this question at the end of the presentation. Now let's take a look at the previous study. The first study is RCT conducted in community pharmacy in Spain that evaluated the pharmacotherapy follow-up program to improve glycemic control, resolve drug-related problem, and increase awareness when compared to the usual care. The study included type 2 diabetic patients on oral medication for at least 2 months and excluded cognitively impaired patients. Results showed significant difference change between 2 groups in terms of drug-related problems, knowledge, A1C, fasting blood glucose, cholesterol, and systolic blood pressure. This study showed the pharmacotherapy follow-up program may achieve positive clinical outcome among patients with type 2 diabetes. The second study is a systematic review published in 2014 that analyzed the effectiveness of intervention performed by pharmacists to improve adherence among patients with type 2 diabetes in oral medication. Results showed that the majority of included study had a statistically significant change in blood glucose and blood pressure in the intervention groups. The study concluded that a pharmacist could have an important role in improving adherence in patients taking oral antidiabetic medications. However, due to the heterogeneity and the deficient quality of the included study, it prevents generalization, and RCT was required to provide additional results. Let me now give you a brief overview on today's study. This is a randomized clinical trial published in 2017, conducted in outpatient, conducted in outpatient clinics in northern Cyprus. Included 152 patients and evaluated pharmacist-led program in improving clinical outcomes in type 2 diabetes patients over 12 months period. The study included the patient diagnosed with type 2 diabetes for at least 6 months with A1C over 7% and prescribed with at least one antidiabetic medication, and excluded uncontrolled psychiatric patients. A1C was the primary outcome, and for secondary outcome, it included the following: fasting blood glucose, blood pressure, lipid profile, body mass index, self-care activities, and adherence. Patients were divided into two groups: 77 patients in control group, where they received the usual care, which include appointment with their physician every 4 to 8 weeks to refill their medications, and 75 patients in intervention group, and they had 5 scheduled meetings with a pharmacist on a 3 months interval. The pharmacist intervention included the following: pharmacists educate their patient on self-monitoring blood glucose, healthy lifestyle modification, and smoking cessation, and they provided different pamphlets at each visit. They also reviewed medication and non-adherence. In addition, they resolved any drug-related problem if present. Finally, they discussed and recommended any changes in medication regimen with the physician. A sample size of 74 patients were required to detect the absolute difference of a minimum of 1% in A1C when taking 15% loss into account. This figure illustrates the allocation. Of 159 patients underwent randomization, 3 patients in control group and 4 patients in intervention group were excluded, and the reason for their exclusion were reported. The next chart shows the baseline characteristic, and we can see that it was similar among both groups. In total, 77 patients in intervention group and 74 patients in the usual care group were female with BMI over 30 kg per meter square. Most common comorbidity were hypertension and dyslipidemia, and the majority of the patients had diabetes over 10 years. Non-adherence at the baseline in the intervention group was 53%, where in control group it was 43%. Next chart indicate that most participants are in metformin and more than half are in insulin therapy. This is a comparison between the two groups in terms of number of prescribed medication. And there was a significant difference between the group where 68% of the intervention group prescribed with 6 or more medications. The results are as shown in this table. It shows that the intervention group achieved a greater reduction in A1C values, and both groups showed a significant reduction in fasting blood glucose. For blood pressure, there was significant decrease in intervention group. Percentage of patients who reached their A1C goals of less than 7% were 16 in intervention group as compared to 0% in the usual care group. And most patients in both groups achieved their blood pressure goal of less than 140/90, which is the target of target blood pressure for patients with low cardiovascular risk. A significant decrease in cholesterol was achieved in the intervention group, and no significant difference were found in other lipid profile values. Also, a significant reduction in body mass index and waist circumference were observed in the intervention group. Finally, the intervention group showed a significant improvement in both adherence and self-care activities as compared to the usual care. Author concluded that a pharmacist-led program reduced A1C and other secondary outcomes in 12 months period. Next, I'm going to focus on today's most important part. The study was published in Journal of Managed Care and Specialty Pharmacy, a peer-reviewed journal with a good impact factor, and it was conducted as a PhD thesis at Near East University. The author did not receive funding nor have any conflict of interest. Patients should be diagnosed with diabetes for at least 6 months to be included in the study. But what about a newly diagnosed patient, for example, with high A1C? I think those patients may need more intensive education on their disease and in their new medications. The study excluded uncontrolled psychiatric patients. So the question here is this justified? For me, I think it's not because, first of all, previous Spanish randomized control trial, patients were excluded only if they are cognitively impaired or they are unable to take care of themselves, which may be more logical. However, we should note that in real life practice, we meet those patients. So inclusion of patients caregiver may make the result more applicable to the practice. When we look at the baseline characteristic, we identify the population that will most likely to benefit from the intervention. For this study, those are obese female patient with long-standing diabetes and insulin and metformin, and most likely to have hypertension and dyslipidemia. As I mentioned before, that there was a significant difference between the two groups in terms of number of prescribed medication. The question here, whether this difference is likely to have an impact on the result. The way I see it, that this difference is unlikely to affect the result. In fact, it may reflect that patients with the polypharmacy may benefit more from pharmacist intervention, since more drugs mean more likely to have drug-related problem that can be solved by a pharmacist. Moving next to the methodology, one disadvantage of randomized clinical trial is low external validity, which affects the generalizability of the result. This study could not be blinded because of the intervention nature. And another point that patients were randomized based on their registration number. This is mean simple randomization. So a simple randomization is trusted to generate similar number of subjects among the groups if total sample is over 100 participants. In this study, the total sample size were 152 participants. The study was a single center study, which have an advantage of generating a greater adherence to the study protocol and have better internal validity because it enrolls a specific population with a relatively homogeneous experimental setting. On the other hand, it usually have a smaller sample size and it can have a personal bias and weaker analysis. When it comes to the intervention, we can clearly see that the interval was longer in the intervention group, 3 months as compared to 4 to 8 weeks in the usual care group. But other than that, both groups were treated equally. And when we look at the pharmacist intervention, it was comprehensive when compared to the previous studies. However, the interval did not involve measurement of clinical outcomes such as A1C and fasting blood glucose. As American Diabetes Association guidelines stated that A1C should be assessed at least twice a year in patients meeting their goals. And in patients they are not meeting their goal, they should be assessed more frequently. Which brings me to my next point. A1C was appropriate outcome for measuring glycemic control. and all other secondary outcomes were clinically relevant and applicable to the practice. Duration used to measure the outcome was 12 months, and it was appropriate when compared to the previous study. The duration ranged from 3 months to 36 months. Even though A1C considered the gold standard in assessment of glycemic control, it does not reflect the hyper and hypoglycemia. It's only provide an average of the blood glucose reading for the past 3 months. Morsky Green test is a validated assessment tool used to measure adherence. It is cost-effective, easy to use in both. However, it can introduce recall bias, which could result in overestimation of adherence. It also can be subjective, where patient may feel pressure to deliver acceptable response to elicit a positive reaction from their healthcare provider. Self-care behavior was measured by the summary of diabetes self-care activities, a questionnaire that focuses on 5 domains. They are diet, physical activity, blood glucose, foot care, and smoking. It assesses the consistency of the behaviors for the past 7 days. It is a brief yet reliable and valid tool, and again, it's useful for both practice and research setting. Power was set to the standard power of 80%, and 74 patients were required in each group. And the power was met since the number of patients included was higher than 74 patients. P-value was reported and not confidence interval. A p-value is the calculated chance that type 1 error, or what's known as a false positive, has occurred. A lower p-value does not mean that the result is more important or more meaningful, but only that it's statistically significant. While confidence interval determine the importance of the findings and reflect the magnitude of difference between the groups. Per protocol analysis was used since not all randomized patients were analyzed. Per protocol analysis provide more information about the intervention efficacy. Since it's only include adherent patient, it may not reflect real-life practice. Primary outcome was statistically significant because the p-value was less than 0.05. But was it clinically significant? Studies have showed that each 1% reduction in A1C levels reduced the risk of death related to diabetes by 21%, and the risk of myocardial infarction by 14%, and the risk of microvascular complication by 37%. For other secondary outcome, percentage of patients who did not reach their blood pressure goals at the baseline was not reported. But blood pressure was already at the baseline less than 130/90 for both groups. Finally, there was a clinically significant result of adherence. It is well documented that poor medication adherence is associated with increased hospitalization, emergency department visit, and often lead to poor glycemic control. For overall strength that the power was set and met, funding source has no impact on the result, and the study had a high completion rate. For overall limitation that the study was a single center with relatively small sample size, only per protocol analysis were used, recall bias when measuring adherence and self-care activities, and finally, clinical outcomes such as A1C was not measured at each visit. Finally, I would like to share my final conclusion and put these results into practice by answering the following question. The first question is this study biased? Roughly speaking, no, except for recall bias when measuring adherence. Are the benefits worth the potential cost? So there are several recent studies published demonstrated the cost-effective benefit of pharmacist intervention, particularly in diabetic patients for preventing the complication. Are the results generalizable? Yes, to some extent, because this result cannot be generalized to all pharmacists, since not all pharmacists are well trained in diabetes education programs. The last question, will this result change the practice? These results are consistent with the previous studies, and the pharmacist role have evolved beyond simple dispensing and is still evolving. And this brings me to the previous study. What can pharmacists add? So pharmacists are the drug expert, and thereby they can have a positive contribution within multidisciplinary team by improving clinical outcome, increasing adherence, resolving drug-related problem, counseling and educating their patient. By that, I reached the end of my presentation. Thank you for your attention. If you have any question, I would be pleased to answer them. Thank you.
Thank you so much, Dr. Lina, for your outstanding presentation and well critiquing of the article. Dear audience, if you have any questions for Dr. Lina, please leave it in the comments so we can discuss at the end of the webinars. Now moving to the next part of our webinar with our expertise speaker, Dr. Umayma Arab. Dr. Umayma Arab earned her bachelor's degree in pharmaceutical science from King Saud University, KSA. And after graduation, she worked at King Faisal Specialist Hospital and Research Center. Then she accepted a scholarship to the States, where she has earned a Doctor of Pharmacy degree from Manchester's College of Pharmacy and Health Sciences. Then completed a postdoctoral training in general clinical pharmacy residency at Columbus Regional Health, followed by ambulatory care residency at Piedmont Columbus Regional. She is a triple American board certified specialist in pharmacotherapy, medication therapy management, as well as ambulatory care pharmacy. She has led the MOH, Saudi Society of Clinical Pharmacy Immunization Delivery Certificate during COVID-19 pandemic. In addition, she was selected to lead the MOH SSCB Medication Therapy Management Certification. She serves as the chair of Ambulatory Care Pharmacy Specialty Network of the SSCB. Currently, she's an ambulatory care clinical pharmacist at King Faisal Specialist Hospital and Research Center. Dr. Arab participates in several events as a speaker and moderator, in addition to conducting research. With a great honor, we are welcoming Dr. Umayma. Dr. Umayma, the screen is yours.
Well, thank you, Dr. Shahama. I am going to share my slides in a minute, please.
Dr. Lina, can you please stop sharing maybe so that Dr. Umayma can share? Yes. Can you try Dr. Umayma now? Because here it's saying all the panelists can share.
There is no icon to click on it for sharing. Does not show it.
Share screen below in the Zoom. Can't you see it? What can you see on your screen below? Can you see mute, stop video?
Yes, mute, stop share video, participants.
Okay.
Then a chat. Now I see it. All right. Okay. Thank you, Dr. Ahmed. Thank you for the
excellent. Excellent. No worries.
All right.
All pleasure.
Is it sharing the right screen now?
Perfect.
Yeah.
All righty. Thank you, Dr. Shahama, for the kind introduction. And thank you, Dr. Ahmed, for inviting me to speak today. One of the greatest and nearest topics to my heart, the role of pharmacy care, pharmacists, and optimizing patient care, or the pharmacist-led ambulatory care clinics. This is near and dear to my heart. So thank you so much. I would like to thank all the attendants as well. I cannot compete with Abdel Majid today's event, but I will have plenty of audience tonight, inshallah. All right, so today I will highlight the evolving role of ambulatory care pharmacy specialists, explore real-life example of successful models by numbers and facts in Saudi Arabia, and all right, and lastly, we'll discuss the available opportunities and needed qualifications for recently graduate or fresh graduate to become distinguished ambulatory care pharmacy specialists. This definition came straight from the ASHP in 2017. It states that the ambulatory care pharmacy practice is the provision of integrated, accessible healthcare services by pharmacists. Now, those pharmacists have to be accountable for addressing medication needs. We're talking about developing sustained partnership with the patient and practicing in a context of family and community. So 3 major things that are included in the definition. Now, ambulatory care pharmacists can work in a hospital-based or a community-based setting to involve direct patient care with a diverse patient population. Now, those pharmacists are involved in several aspects of the ambulatory care clinics. It can be direct patient care with straight medication therapy management for those patients. It can be long-term relationship with patients to establish that rapport where it helps the patient to trust the practitioner or the pharmacist, so they can be giving more to their medication, say adherence. If they have this trust, they will have more trust in their pharmacist and therefore to their medications. Also coordinate the care, being the pharmacist, also being patient advocacy, providing wellness and health promotion, triage and referrals is one of the things that a pharmacist in ambulatory care setting can do, and also patient education and self-management. So these are the main things that the ambulatory care pharmacist is involved in. Here is the 3 major things that the pharmacy or ambulatory care pharmacist can provide. We're talking about following treatment guidelines, up-to-date guidelines, where you can fill all the gaps with all the new things that are happening with the associations or organizations globally and nationally. Also utilizing most cost-effective drug regimens. So helping the pharmacy, the patients by reducing out-of-pocket, for example, or using their insurance correctly, or the medication that can be effective as equivalent if it's the brand or other generic or other medication. And lastly, educating patients or caregivers for their medication and disease states or lifestyle modifications as well. So ambulatory care pharmacists provide comprehensive medication management for a wide variety of patients with chronic health conditions. They work closely with other members of healthcare team, including physicians, nurses, behavioral health specialists, and others. Also, they can have an expanded scope of practice depending on their institution and practice location. Most institutions allow for collaborative practice agreements, which enables pharmacists to initiate, adjust, discontinue those medications, or order and monitor lab studies, also perform limited physical assessments. So pharmacists have a very wide range of roles in the clinic. Now, here I have this slide, which has more than just these 2 graphs. The pharmacist patient care process is a very important process that can be implemented with any model that the pharmacist is in. So for example, in the transition of care, it can be there. For medication therapy management, it can be applied as well. First of all, the pharmacist assures to collect the necessary subjective and objective information about the patient, whether it's understanding the relevant medical or medication history, clinical status of the patient, information that can be gathered from multiple resources such as patient themselves or patient records or other healthcare providers, collecting things like medication lists, medication use history, prescription, non-prescription medication, herbals, and medical history, health and wellness wellness, biometric results, all these kind of things can be collected in the first step. The second step is the assessment, where the pharmacist assess this information that has been collected and analyze it, analyze the clinical effect of the patient therapy in the context of patient's overall health goals. And that is to prioritize the problems and to achieve optimal care. This process includes assessing each medication appropriateness, effectiveness, safety, and patient adherence to the medication. Also, it can assess health and functional status, risk factors, health data. We're talking about also cultural factors, health literacy, and access to medications. So all these things, when it's gathered, then you can assess it and after that, plan accordingly. So the pharmacist develops individualized patient care plan that is custom for this patient specifically. It includes establishing a care plan that addresses medication-related plan. It can be with other healthcare professionals or caregiver to assess the related problems and optimize the medication therapy, set goals for the therapy, and achieving clinical outcomes in the context of patient overall healthcare goals. Also engaging the patient in the education, empower the patient, and self-management, support their care continuity. So this is part of the plan. Implementing the plan is a very important part of this cycle, because the pharmacist implements the care plan in collaboration with other healthcare professionals and the patient or the caregiver. So during the process of implementing this plan, it can include addressing medication and health-related problems, engaging in preventative care, and including vaccine administration, initiate, modify, or discontinue treatment regimens based on the patient's medication-related problems. Also provide education and self-management training for the patient or the caregiver. And last thing is the follow-up. The follow-up and the monitoring of the status change is important, because the pharmacist at this point will evaluate the effectiveness of the care plan and modify the plan in collaboration with the other healthcare professionals or with the patient as well, because it is again a sharing decision here. So the process includes the continuous monitoring of evaluation of medication appropriateness, effectiveness, safety, and the patient adherence through available health data. With that, the cycle is actually closed. So each time thinking about the patient, pharmacy patient care process, this is the patient-centric care. Here on the right side, you can zoom in and see the different, excuse me, see the different places where the pharmacist can be involved and find interventions where can find medication-related problems. Unnecessary medication therapy, needing additional medication therapy, ineffective medication, dosage too low, needs additional monitoring. This form is available through the APHA, and it's really helpful for collecting the data and assessing and planning accordingly and implementing the necessary changes to the patient medication regimen. Now I will move to another form that I really like and I really use it a lot. This form is the medication-related problem list, where you can, it's categorized based on the categories that says the first one, unnecessary drug therapy. Second one is drug selection, not optimal, clinical significant drug interactions, medication dosing regimen, not optimal, adverse drug reaction, needing for additional drug therapy, failure to receive drug therapy appropriately, needing for additional follow-up. So these are the major categories, and these are the things that when I see a patient or before I see the patient, I prepare for the visit. I look at it and see if there is any problem with the medication, for example, medication duplication, an indication without medication, preparing beforehand and looking at this form after the visit helps a lot for giving recommendations and interventions to the physician if needing approval from the physician to be changed. And under collaborative practice agreement, this is something that is really helpful. So you can follow specific protocols and move on from there. Excuse me. Now, I'm going to talk about the components of safe medication management. And I included this slide because it's really important to have the core of the medication management here. We're talking about this possible medication history. This possible medication history is a history created under using main things, a systematic process of interviewing the patient and the family. And the second one is reviewing at least one other reliable resource of information to obtain and verify all patient medication use. And that includes prescription, non-prescription, and herbal medications, and is more comprehensive than a routine primary medication history, which is often a quick preliminary medication history, which may not include multiple sources of information. And the second part, the second step here is the medication reconciliation. It's a formal process which a healthcare provider work together with the patient to ensure accurate and comprehensive medication information. And moving from there, you can reach to the clinical medication review and medication management. In the pictures below, you can see upon admission, the patient comes in, you can ask the patient about the medication. If you can look here, I'm pointing at it. So you can ask the patient about the medication, collect the right information, go again with verifying it through retail pharmacy or the hospital pharmacy they pick their medication from, and then complete the medication history list. Moving to pharmacist-led care clinic in Saudi Arabia, I will discuss this in a later slide, but here I have some models before I go in Saudi Arabia. So we have a lot of models that we can follow here for pharmacist-led care. Medication therapy management can be conducted in a community pharmacy or a hospital-based pharmacy. Also, it can be implemented as the pharmacist-led care clinic as a transition of care clinic. It can be partnership with medical homes, nursing homes, or long-term care homes. This can all happen under a collaborative practice agreement with the prescriber. This agreement that I was talking about helps a lot the pharmacists to work under a protocol where they can modify the treatment regimen, initiate, discontinue based on the protocol they have in hand. Or it can be mixed of all these options together. Now, MTM or any of these medication therapy management can happen with in a comprehensive medication review or a targeted medication review. Comprehensive is a systemic process of collecting patient-specific information, and it has all the list of all the disease states the patient have, medications the patient has, while the targeted medication review addresses a specific or a potential medication-related problem in particular. And that is to assess medication use, monitor whether any unresolved issues need attention, or determine if a new drug therapy problem have arisen. And it's a plus if it's combined with medication reconciliation. And also it is really good to have these services combined with disease state management, group patient education classes, or collaborative drug therapy management. It optimizes your setting where you can give interventions or do interventions on the spot. Now here, this is an appointment-based model. It's really a nice one. I found it on APHA. It is when the pharmacist, it's like an integrated process where the pharmacist, the patient comes to the pharmacy for dispensing a new medication or refill prescription. At that point, the pharmacy staff will explain the appointment-based model and have the patient enrolled in this service if they are welcoming. So the pharmacist will collect all the information, synchronize all this dispensing medications to the same period of time, At that point, and you can see it here on step number 7, where the pharmacist, after receiving potential changes for the patient medication, the pharmacist prepare the prescription, and here you can see the pharmacist review the comprehensive prescription order, evaluate for medication profile, and at this point they can do interventions. So on the next visit, when the patient comes to the pharmacy to pick up the medication, they have more like a counseling service along with medication therapy management services, which can include performing a comprehensive medication review. This model is integrated outpatient and ambulatory care clinic together. Now I will move to ambulatory care pharmacy specialist in Saudi Arabia. This study has included all the ambulatory care pharmacy studies that has been done in Saudi Arabia. Those and the orange lines are the diabetes care clinic. We have 4 of them that are published and included in this nice review. I want to mention that most of these studies included pharmacists as part of the multidisciplinary team, or it was in a community pharmacy. It measured A1C or also blood pressure and lipid panel. It included also satisfaction, patient satisfaction. These studies had shown reduction in A1C over that period of time, and it was significant reduction in A1C. So pharmacist-led or pharmacists participating in these services has improved the clinical outcomes of diabetes. We have also services like heart failure, epilepsy, anticoagulation, hemodialysis units. So we have a variety of clinics that are documented in the evidence in Saudi Arabia here. Now, this is a whole wide range of services that a pharmacist can provide in a diabetes care. Now, we don't have to provide all these. It depends on your institution, your patient population, the care that you should be providing in your clinic. For the beginning, maybe we all do blood glucose reading, assessing current glycemic control, modify regimens, order labs, read labs, monitor it. Also, part of the diabetes care is that cardiovascular disease risk assessment should be included. We have experts who can or are comfortable to do diabetic foot exams. They have, in the United States, they have also this screening for depression, especially which each visit they administer the specific survey to have the depression screening. Also, educating patients upon using glucometers, appropriate use of medication, help them to obtain their medications and have access to their diabetes education classes, ophthalmology, nutrition, also referring those who are in need for specialists as well. So these are very wide range of services that we can provide. Now, in the United States, I selected 3 major studies, and I selected those who were conducted in by sponsors or employers, because they look at clinical outcomes and at other outcomes that including direct or indirect costs. So here is the Ashford Project. It is one of the biggest or well-known studies in the past. It has included 85 patients in North Carolina, assessed A1C. There was reduction in A1C with those pharmacists who conducted these visits. But also I want to mention here, so the cost has increased significantly. That was, and that can be explained by adherence to medication, using glucometers and these kind of things. But also there was a reduction or decrease in the all diagnosis cost of care. So there was an improvement in A1C and total reduction in medical costs as well, decline in mean total direct costs. Same here is with diabetes care. So this one also included clinical outcomes and humanistic outcomes, and looking for services and satisfaction of the overall diabetes care. There was also significant enhancement with the outcomes, the clinical outcomes and the heuristic outcomes. And the last one here also is through employer sponsorship. Again, the mean A1C was decreased, and the significant improvement in other panel was decreased as well, the triglyceride, total cholesterol, and blood pressure. So these three studies I included very quickly just to show that we can have really good impact on the clinical outcomes and the economical outcomes of the economic, pharmacoeconomic outcomes. Here is, I have two more places where a pharmacist, ambulatory care pharmacist can be involved, the transition of care. And this is a clinic that I have established in King Faisal Specialist Hospital. It aims to provide essential health care and medication reconciliation to patients who were discharged from the hospital within 5 to 14 days. It's provided by ambulatory care clinical pharmacists under the CPA with medicine department. It targeted patients, adult patients who are at high risk for readmission, acute or chronic disease states, complex drug regimen. We're looking at service in this clinic. We serve them by reconciling their medication, assess the patient's therapeutic response, drug toxicity, compliance, and monitoring ability and medication knowledge. So in this clinic, the major interventions that we look at is medication reconciliation, disease state education, medication counseling, lab monitoring, and MTM. During this year, where it was established, when it was established in March and up to date, this is the booked number of patients. We had about 83 patients showing to the clinic with 240 interventions in the clinic. Studies from outside actually showed that there is a reduced readmission rate as low as 8.9% and up to 30%. Those patients who are 65 years or older had, I don't want to say a reduction, but actually in the usual care group, there was a 6-fold increase in the odds ratio of readmission to the hospital within 30 days. So probably those patients had lower incidence of readmission to the hospital. Also benefits including avoiding unnecessary long hospital stay, decreased expenses associated with length of stay, reduction of risk of nosocomial infections, and assisting the physician in follow-up. Now, the last service that the pharmacist in the ambulatory care setting that can provide is telehealth. So telehealth has expanded a lot significantly during the last 3 years, especially with Corona or COVID pandemic. Now, the terms has been used interchangeably: telehealth, telemedicine, telepharmacy, but the ASHP has defined the telehealth as it seems to be an overarching term for the remote delivery of patient care services. In the pharmaceutical care virtual clinic, you can apply this checklist for any type of clinic as you are in your institution. If it's for transition of care, diabetes care, asthma care clinic, give this checklist to your patients so they can follow and monitor themselves. Track before or one day before the visit, track how they are feeling, collect their medication and have it available, write down questions and what they want to get out of the appointment. Also clarify how to connect with the provider using smartphones or other webcams. In the morning of the visit, make sure that they have their home readings, whether it's blood sugars, blood pressure, body temperature. Make them feel that they're the appointment. So ask them to wear properly and find a quiet spot to attend to the visit. Now, benefits including flexibility of the appointment scheduling, ability to visualize patients in their own environment, having them taking their medication at home, especially when it's diabetes medication injections, also understanding their medications from their own perspective. Also serve patients in distant geographical location and promoting for social distance. Now, some challenges can include resources, availability of resources for those patients. Maybe they are geriatric or patients who are not very well in using technology. But in general, we can have these computers or desktop in our clinics and have the camera on and have the patient on the other side. Now, to set up this system for success, you have to look at two things, the hard metrics and the qualitative metrics. With the hard metrics, look at numbers of patients seen via telehealth, reduction in the no-shows numbers, also clinical outcomes. But for the qualitative measures or metrics, it's the satisfaction of the patient and the staff in the clinic. Also compliance with treatment as a result of success, convenience, and continuity of care. I'm not going to take too long. Last thing here is about the ambulatory care pharmacist. Now, in Saudi Arabia, we don't have a specific or exclusive requirement to be an ambulatory care pharmacist. However, we follow the United States, where they have as a PGY1 as a minimum competency for providing ambulatory care services in the States. And it would be optimum with a accredited PGY2 specializing in ambulatory care. Now, additional specialty board certifications such as pharmacotherapy specialist, board certified medication therapy management specialist, or if it's geriatric, I'm talking also about board certified ambulatory care pharmacy. Those are the type of specialty board certification that they can add to your CV or your points when you go to apply in any institution. Also clinical experience, if you go to an area where you work for an institution and it has a long history of ambulatory care services, you continue the training hours and you're doing very well. This is your clinical experience then. And last thing is continuing education certification program. So the ASHP actually offers a lot of certification through their website, and it's available to add to your knowledge and your skills as well. And with that, I wrap up my presentation. Thank you so much for listening, and I will be happy to answer any questions. Thank you.
Thank you so much, Dr. Umaima, for your amazing and informative presentation. For me, I really enjoyed your presentation about how critical our role in managing patients, especially in the ambulatory care. Now, dear audience, if you have any questions for Dr. Lina or Dr. Umaima, you can please write it down in Q&A box. Dr. Lina, are you with us? Okay, so starting with the first question of from Atil. You mentioned that the psychiatric disorders may or may not prone to diabetes. Is the depression and diabetes is bidirectional? And if yes, then how it may affect the causes of hyper or hypoglycemic effects? To define my question, I will quote this. According to research, 37 of depression may cause diabetes type 2.
Thank you for your question. Actually, I mentioned before that the study, the RCT excluded patients with uncontrolled psychiatric disorder. And that's what for me was unjustified because as an exclusion criteria, because in real life practice, we meet those patients. So inclusion of their caregiver would make the result more applicable. I hope that answered your question.
Thank you so much, Dr. Lina. Dr. Umaima, what do you think if there's any special circumstances for patients with psychiatric disorders in ambulatory care clinic?
To my knowledge, there are actually several clinics that are available worldwide and in Saudi Arabia. We have, to my knowledge, the psychiatric clinic in Cleveland. Is it Cleveland? Aramco, yeah. So it is one of the places that I know they have this services, and I heard a lot of good things about it.
It's amazing. Atik has also another question. So what's the reason of the high fasted blood glucose level without eating in the morning? They may lead to the patient's stress, and the stress itself increasing the blood glucose level. Then how we can manage that, Dr. Umaima?
Well, this is a question that should be taken to the specialist, because there should be lab done and things to be evaluated before we just go ahead and say this should be given as a medication. It is part of the diabetes that there is some fatty liver that can be progressed with time, but again, it should be taken to a specialist in the clinic.
Amazing. Another question, how's the antibiotic prescription? So we manage most of the chronic conditions in the ambulatory care. So how is the antibiotic prescription can be managed in the ambulatory care services?
Can you repeat the question? Is it about antibiotics?
Yeah, antibiotic prescription, how we can manage it in the ambulatory service.
So to begin with, infectious disease clinical pharmacists should be involved in the consultation of these prescriptions if it's an ambulatory care pharmacist-led clinic. We don't really do a lot of prescribing unless there is a privilege or a list of medication that should be included in the CPA where the pharmacist is allowed to prescribe these medications. Now, in some places, we have to consult our physician and prescribing or changing the antibiotic. We should not advocate for a lot of antibiotic dispensing if it's unsupervised or unobserved with healthcare providers. Now, in ambulatory care, if it's chronic diseases, we do some medication changes and medication adjustments, but not including a lot of antibiotics, honestly.
That's amazing.
Unless it's prophylaxis, if something should be followed again with specialists, if it's prophylaxis long-term use.
Dr. Lina, this is a question for you. Thank you for providing such valuable information. My question, did the socioeconomic status of the study participants influence the rate of adherence to the intervention? If yes, how did you optimize such an obstacle in data analysis?
Thank you again for your question. Actually, they did not mention about the socioeconomic impact on the adherence. They only reported how the percentage increased after the pharmacist intervention. However, in the baseline characteristic, most of the patients were not, they didn't have a higher education or they didn't have a college degree. So, but they did not link the two variables together.
Okay, thank you, Dr. Lina. Anwar is asking, may I know about the model that could be used in patients with Alzheimer's disease, if there's any specific model, Dr. Umaima?
For cognitive disease management, it's a specialty where we have if it's an ambulatory care pharmacist who's taking care of this type of clinic, it has to have this specific criteria where they can run this clinic. For example, having the board certification for this specialty. Now, if it's through geriatric clinic, it can be hand in hand with the physician, with the primary care physician. If it's solo, again, it goes through the specific protocol that they have in the clinic. I don't do a lot of these type of clinics, but I think if it's asked to the right person, then maybe we would have a good answer.
Excellent, Dr. Umaima. Tiff is asking another question for Dr. Umaima. Most of the patients worry to take the insulin therapy, but if they have A1C of more than 10, what's the rule of pharmacy to convince them to take the insulin because the oral medication will not help in such high A1C?
So basically, we should follow the new guideline, the ADA 2022 guidelines. It states that the patient should be optimized on their medication with the new agents, the GLP-2 inhibitors and GLP-1 inhibitors and the agonist and the SGLT2 inhibitors. Now, if the patient requires insulin injections at any point, especially if it's above 10 like this percent, there are some ways that we can use with the patient to convince them about using insulin. Have them trained with the diabetes educators. Those educators know very well how to find a comfort zone where the patient can actually start injecting themselves and have them do it by themselves as well.
Yeah, it's a very critical point for the counseling the patients how to use the medications. Dr. Imam, I have a question for you. What's the obstacles that you may face during the COVID pandemics? So many patients may not visit the pharmacist clinic. How did you manage that, and what's the obstacles that you found that?
Yeah, it happened actually with many clinics before even it reaches to the pharmacy clinic. During the COVID pandemic, and the clinic was running, the anticoagulation clinic was running, the transition of care pharmacotherapy clinic was running. I actually personally had to submit a form for virtual care clinics. So there was a parallel clinic for patients who are in their homes needing to be in social distance so we can conduct the visit safely virtually.
Amazing. Especially for those geriatric patients and the polypharmacy, I think it's very critical to follow up with them. And even though with the telepharmacy, I think we can reach that one.
Yeah.
There's another question from Anonymous. How is narcotic drugs managed in ambulatory care pharmacy? Dr. Amima again.
And this is really one of the biggest issues that comes through our clinic, especially after hospitalization at the transition of care. We assess the need of the controlled medication or narcotic medications, and it's always referred to the prescribing physician. So they have to be referred to the prescribing physician for assessment of actual need of these medications. It has to go through them anyway.
Amazing. With that, we reached to the end of our webinar. Thank you again, Dr. Amima and Dr. Dina, for your amazing presentation and speaking with that. Dear Spectre audience, thank you for attending the first IVPN Journal Club webinar. And again, going to Ahmed.
Thank you so much, dear Shahama, for your amazing efforts in moderating this fantastic, really, event, and very interesting, enriching Q&A's period. I really enjoyed every second of the presentations, and the smart questions also we heard. That really shows how engaged our audience are with our amazing experts. Dr. Lina, Dr. Umayma, thank you so much for sharing your valuable time with us this evening and expertise. For our audience, it was truly insightful by all means, and we really look forward to more collaborations with IVPN Network in the near future, inshallah. Please note that certificates of attendance will be shared to all attendees within 7 days, and the session's recording and presentation slides, as shared by our speakers, will be uploaded also on the IVPN library website within 15 days. And with this, we come to the end of our Journal Club session for today. I would like to deeply thank each one of you for your active presence and making this session as interactive and fruitful as possible. Stay tuned for more upcoming new activities in Journal Club listserv. If you are not yet part of IVPN Network, please visit our website www.ivpn-network.com and register to our listserv, including Journal Club and others interesting listserv as well. And you saw also during the discussion, we displayed the social media channels of Journal Club listserv. Please make sure to follow us for many endless opportunities. And thank you for your trust in IVPN and passion in advancing your expertise. Have a good evening or rest of the day, wherever you are. Goodbye and take care. Thank you.
Thank you.